All right, let's play detective. Today, we're diving into a medical mystery, one that often starts with some really vague clues, but it can be cracked wide open with just one simple, crucial piece of evidence. So, let's get our investigation started. The case usually begins with symptoms like these. They seem pretty simple, right? Maybe even easy to just brush off. But for us, these are the first breadcrumbs, and they're leading us down a very specific path, pointing to a problem that's happening deep down inside our cells. So, here's our game plan. First, we'll figure out what exactly we're looking for. Then, we'll look at our first clue, the CBC. After that, we'll narrow down our suspects, find out where they came from, map out the road to recovery, and then wrap it all up with a checklist so you can solve this case every single time. Okay, first things first, what are we actually dealing with here? Megaloblastic anemia isn't just about not having enough red blood cells. Nope, it's way deeper than that. It's about a complete breakdown in how those cells are even made. It's the weird story of cells that get big, but they just can't grow up. Here's the official definition for you. It's a type of macrocytic anemia, which is just a fancy way of saying the red blood cells are way too big. And the real root of the problem, it's a glitch in making DNA, and that glitch is almost always caused by not having enough vitamin B12 or folate. Think of those two as the essential building blocks for DNA. So this mismatch is the absolute key. Without B12 or folate, the cells can't make new DNA the right way. They can still grow their insides, get bigger and bigger, but when it's time to actually split into two new cells, the whole process just grinds to a halt. And this hits the cells that divide the fastest the hardest, especially the blood cell factory in our bone marrow. And that brings us to our number one piece of evidence. The key that unlocks this entire mystery almost always starts with a complete blood count, or a CBC. It's a simple, routine blood test, but it's where the first huge, unmistakable clues show up. This right here, this is like the fingerprint of the condition. So first, you're going to look at the MCV. If that number is over 100, boom, you know the red cells are too big. That's our macrocytic clue. Then low hemoglobin confirms, okay, we're dealing with anemia. But the real smoking gun, the thing that really cracks the case, is what you see on the blood smear. You're looking for two things, hyper-segmented neutrophils and these large egg-shaped red cells called macroovulocytes. You see those two together? That is a classic textbook sign of a megaloblastic process. Okay, so the CBC has basically screamed, it's megaloblastic anemia. So now our investigation gets a lot narrower. We have two main suspects for this whole DNA mess, a vitamin B12 deficiency or a folate deficiency. Now we have to figure out which one it is. So this is the big question we've got to answer. And trust me, getting this right isn't just for bonus points, it is absolutely critical for the patient. Why? Because one of these suspects carries a very specific danger that the other one doesn't. Let's break down how we tell these two apart. Now, you'll notice both of them can raise something called homocysteine in the blood, so that doesn't really help us, does it? So how do we know? Well, there are two dead giveaways. First, only B12 deficiency causes neurological symptoms, that numbness, that tingling, because B12 is crucial for the protective coating around our nerves. Second, we can test for something else, methylmalonic acid, or MMA. Its levels go up only in B12 deficiency. That lab result is the definitive tiebreaker. Case closed. And this brings us to the single most important rule of this entire investigation. You have to hear this. You must rule out or treat a B12 deficiency before you even think about giving folate. Why? Because giving folate is tricky. It can actually make the blood picture look better, it can fix the anemia, but, and this is the scary part, it does absolutely nothing to stop the nerve damage from the B12 deficiency. In fact, you're just masking the real problem while the person's nervous system could be suffering permanent, irreversible harm. So now we know how to tell our suspects apart. Let's do some real detective work and trace their origins. Why would somebody become deficient in these vitamins in the first place? You have to understand the root cause to really solve the puzzle. Well, the reasons can be all over the map. For B12, a strict vegan diet without any supplements is a pretty common cause, since B12 is mainly in animal products. But honestly, more often it's an absorption problem, like in pernicious anemia or after stomach surgery. For folate, it might be as simple as not eating enough leafy green veggies. And for both, some medications or conditions like pregnancy can just make your body demand way more than usual. Let's make this real with a classic case. Meet Mr. Patel. He's 68, he's tired, he's pale, and he's got that telltale numbness in his feet. His CBC shows a high MCV. His B12 level is low. That numbness, that's the huge clinical clue pointing the finger directly at a B12 deficiency, probably from an absorption problem that's pretty common in his age. And now, let's look at the flip side. This is Miss Shaw. She's 28, she's pregnant, and she is exhausted. Her labs also show megaloblastic anemia, but her folate is low. For her, the cause is totally different. It's the huge demand for folate that pregnancy creates to help the baby develop. And notice, no neurological symptoms. That points us away from B12.
So, we've identified the problem. We've found its root cause. The case is cracked. Now we're in the final phase, management. Let's outline the path to recovery. How do we actually fix this?
The good news is the plan is pretty straightforward. It's a simple 1-2-3 punch. 1, confirm exactly which vitamin is missing and why. 2, replace it. B12 shots, high-dose pills, whatever it takes. And 3, monitor. You've got to watch the patient's response to make sure the fix is actually working. And the body's response is really predictable. It's amazing. You can actually watch it happen. The very first sign of success pops up within a week. You'll see a big jump in reticulocytes, which are basically baby red blood cells. That tells you the factory in the bone marrow is back online. Then hemoglobin starts to climb. But look at that last point. Neurological recovery? That can take months. And if the problem was really bad or went on for a long time, the damage might not be completely reversible. Wow. Okay, we have covered a ton of ground here. So to make sure you're ready to crack this case every time it comes your way, let's boil everything down into one final essential checklist. Here it is, your cheat sheet. If the MCV is over 100, your first thought should be megaloblastic. Go look for those classic shapes on the smear. Always ask about their history, diet, surgeries, meds. Use your labs wisely, especially MMA when B12 is on the fence. And please, remember the golden rule. If there is any doubt, treat for B12 first. And finally, look for that proof of recovery in the blood. So, as we close this case, let's just go all the way back to that very first clue, Mr. Patel's numbness. That one symptom is the ultimate reminder of what's really at stake here. See, solving megaloblastic anemia isn't just about fixing a number on a lab report. It's about protecting the nervous system from damage that can last a lifetime. It's a powerful lesson. It's not just about the blood, it's about the brain.